So hi everyone, I'm Kirsten. I'm working for Doctors Without Borders, or Médecins Sans Frontieres in Khayelitsha in South Africa, and I'll be talking about how we've adapted HIV services to challenges posed by COVID-19. So just a bit of a background about the community that we're working in, called Khayelitsha. So it's a peri-urban informal settlement around 35 kilometers outside of Cape Town city center. It's a low-income area. It has a population of around 500,000 people and a high prevalence of HIV. The overall prevalence in South Africa is around 20.4%, and pregnant women in Khayelitsha is around 34.3%, which is slightly above the national average at 29. So the HIV services in Khayelitsha, I'm going to give you a bit of a background as to what it looked like before. But HIV services have changed vastly over the years to make it easier for patients to be managed, to improve health systems efficiency, and encourage people to have retention and care. Much like you would have clinics that are dedicated to sexual health or to women's health, in South Africa with a high burden of HIV, we have clinics that are dedicated to HIV care, and it's staffed by people who are experts in HIV care and focus on HIV related problems. So one of the elements of this is that we have at what we call adherence clubs, and we try to get as many people onto an adherence club as possible, and their care is very structured. So they get one visit by a doctor a year and a visit from a nurse every 2 months, and collect medication when they visit a nurse, and then one blood check every year. And it's very structured. People have their schedule for the entire year, and patients are monitored if they don't return. So if they fall out of the system, somebody phones them, or they get a visit at their home to check where they've gone. There's also opportunities for people to pick up their medication at certain collection points, or for someone to collect medication on their behalf. And this allows us to deal with some of the issues that people have with taking time off work and with mobility issues. The adherence clubs also provide support groups and group counseling. And in some of the clinics, they have specific services for people who are struggling. So this might be done through what we call patient ambassadors, and these are similar to sponsors that you would have in drug rehabilitation services, where somebody with HIV who's controlled will provide peer support for somebody who's not controlled. They may also provide additional adherence counseling, and patients are given more frequent follow-up and monitoring. So these services are designed to try and fit the traditional World Health Organization targets, the 1990 targets. And these basically mean that we need to get everybody who's HIV positive, 90% of them should know their status, and of that 90% of them should be on treatment, and of that 90% of them should be virally suppressed. And by virally suppressed, we mean that people are controlled on their medication so that their immunity is maximized and they're at a reduced risk of mortality. The problem with these targets is they're very linear, and particularly in low middle income countries. So it makes the assumption that people are diagnosed with HIV, they then start antiretroviral therapy, and then they are suppressed. But it doesn't take into consideration for people who actually leave care. And the new thinking is that actually people can leave care at any point in their treatment journey. So somebody can be diagnosed with HIV and actually never start treatment. Someone can be started on treatment and then disengage, or somebody can be on treatment for many, many years and be virally suppressed, but then disengage from care. And that might be due to treatment fatigue or other socioeconomic issues. And when we say disengage from care, we mean either people are not taking their medication or they're not going for their clinic visits. So what MSF has been doing over the past few years is they're targeting people who are not coping on HIV care. And this includes those who are non-adherent, so people who are not taking their medication or not going to their clinical visits, or people who are virally unsuppressed. So this might be because they're having side effects from medication, they have drug resistance, or they're just not taking their treatment. And then also people who are at risk of becoming non-adherents, so people who are struggling with psychosocial issues that could push them over the edge. So MSF tries to design strategies that encourage engagement in care and encourages long-term retention in care. And we do this by focusing on some of these psychosocial determinants of health, looking at the tipping point model. So the idea of this model is that we can look at for reasons why some people adhere to care and some people don't. It takes into consideration a combination of external and internal factors that influence health behavior. One factor alone might not cause someone to stop taking treatment, but a combination of factors might, where only one additional challenge is needed to push someone over the edge. For example, you can have two people who are on HIV treatment and both of them lose their jobs. One stops taking their treatment and the other one continues. The one who stops taking their treatment might have had other competing challenges such as mental health issues, financial insecurity, or domestic violence. And the job loss triggers them to stop taking treatment, but actually there were many other factors contributing to their difficulty. So what MSF tries to do is tackle some of these factors to build patient resilience and prevent people from tipping over should they experience additional challenges. So I won't go into detail about what these are, but we focus on trying to tackle a lot of these issues using this model. And this is particularly important during COVID-19 because these socioeconomic barriers to engagement are now magnified. And it's not just COVID-19, but some of the effects of lockdown that could be pushing patients over into non-adherence. So some of the challenges that COVID-19 has brought are both related to healthcare and those that are related to lockdown restrictions. So firstly, healthcare services are massively downscaled, and HIV care absolutely has taken a backseat and been forgotten about in many ways. The emergency response has been prioritized. There's reduced staff capacity because people are sick. There are social distancing restrictions, so fewer people are allowed into clinics and into hospital facilities. So people are given fewer clinical follow-ups. There are also lockdown restrictions. So with the reduced transport, both staff and patients can find it difficult to get to healthcare centers, and there's also a disruption in the supply chain. In addition, there's some psychosocial issues that are magnified, which contribute to the tipping point model, such as job loss and financial insecurity, mental health issues such as fear, anxiety, and depression, gender-based violence, and substance abuse. What we need to remember is that HIV care is a really important part of the COVID-19 response. And this is because we want to achieve viral suppression. So just a reminder, the viral suppression is meaning that people are controlled in their antiretroviral therapy, and this improves immunity, it reduces risk of infectious illness, and reduces mortality. Although we don't know about the specific impact of COVID-19 in patients with HIV, it's a very new disease, so we don't have a lot of research about that specific relationship yet. And being on effective antiretroviral therapy also means that people have fewer visits to the clinic and hospitals, as well-controlled patients will get sick less often and require fewer clinical visits. And this also means that they'll have reduced exposure to COVID-19 patients at healthcare centers and reduced exposure when they're taking public transport. It also means that healthcare services can be prioritized for COVID-19 emergencies. So some of the adaptations we've made to the services that we're providing in Khayelitsha is we've done these in collaboration with the Department of Health and with other stakeholders. We're not doing this in isolation. So when COVID-19 was announced as a pandemic, the Department of Health passed a policy to allow for longer prescriptions. So Previously, patients were only allowed to be given 1 to 2 months of medication at a time, but now we can dispense up to 4 months of treatment, and scripts no longer expire after 6 months, but they now expire after 12 months. And even though this policy was passed by the Department of Health, implementing it was another challenge. So MSF supported the clinics to implement longer dispensing for patients to get up to 4 months of antiretroviral therapy at a time. Another service that was provided by the Department of Health was home delivery of medication with the help of MSF. So instead of people coming to the clinic, they could get their medication delivered to their door. And these elements might seem like very simple changes, and in many high-income countries, these are already being done and are possible. But there are practical challenges that exist in South Africa and other lower-income countries that have prevented us from doing this before. Something else we're providing is telephonic consultations. So now that patients are getting longer prescriptions of medication, they're also having contact with clinics less often. So in between their clinical visits, they are being followed up by a nurse and a counselor who can look for red flags that would have been identified if they've gone to the clinic. So that we're still continuing a good quality of healthcare despite the challenges posed by social distancing and other lockdown restrictions. We're also actively trying to find people who've stopped taking their medication and helping them return to care. So MSF is specifically doing this in different locations. So we are engaging with people working in hospitals to find people with advanced HIV who've been admitted, who are not on treatment, and supporting them to return to care by providing them with counseling over the phone and a follow-up from a nurse at regular intervals. We're also doing this through social media campaigns. So we have a Facebook page that people can send messages to, and we give them advice on how to return to care. And also using radio advertisements to encourage people to return to care, and kind of focusing it on the importance of people being on antiretroviral therapy during COVID. So some of the challenges that we've experienced, getting a buy-in from the stakeholders and from the staff and the community has been challenging. And in addition, there's been some concerns about stigma and confidentiality, particularly with patients getting medication delivered to their homes and getting phoned while they're at home, as a lot of people haven't disclosed their HIV status to their families. So some of the practical resource limitations include access to phones. So this does tie into confidentiality of it, as many patients don't have their own phones or they share phones with family members. So there was a concern about confidentiality. And many clinics, even though they have phones, don't have the phones accessible to the staff who work there. So even if we wanted to provide telephonic support for patients, it's physically not possible in some locations. And then data capture and admin systems, it might seem like something very simple, but in a clinic where we don't have access to computers or internet, or people with organizational and technical skills, it's very difficult to make big changes into how data is collected and to how we have an effective monitoring and evaluation system. So some of the lessons we've learned, the longer prescriptions have so far been a success. It has allowed patients to have fewer clinical visits. It meant that people have less exposure to COVID-19 because they don't have to take public transport to get to clinics, and they don't have exposure to people with COVID-19 in clinics. There are shorter queues at the clinics, and people have better adherence to treatment. In previous qualitative research, we found that one of the biggest barriers to people taking treatment is that they have to go to the clinic very frequently and sometimes wait an entire day just to collect their medication. So by providing longer prescriptions, we're supporting patients to adhere to their medication. Medication delivery has similarly allowed people to spend less time in clinics and thus reduce the workload for the staff and improved the lengths of the clinic lines and adhere to social distancing. The telephonic consultations have allowed patients to receive support despite not being able to go to the clinic. And patients have actually been very receptive. So despite what healthcare workers had thought, where we had assumed that everybody wouldn't want to be followed up because of confidentiality, this wasn't the case. There were very few who were concerned about non-disclosure. So, what have we learned from these experiences? There are not a lot of good things that come out of a crisis and out of an emergency, but we have learned something new here about healthcare, and that's how we've had a chance to reinvent how healthcare is provided. We've learned about feasible ways in which services can be improved. We have been forced to tackle systemic issues that would not have otherwise been prioritized. In order for an opportunity to be created, we need not only a problem and a solution, but it needs to be a priority. It's really forced us to put away our political agenda and work together to fight a common enemy. And this is really one of the core beliefs of MSF, and that is to be impartial and independent and provide care based on need. So this emergency has forced us to learn how to adapt to change as the COVID-19 strategy is rapidly evolving. It shows us how rigid our system is to challenges, it highlights gaps, and it forces systemic issues to be fixed. So what happens next? Do we go back to how things were before? Do we sustain changes that had good outcomes? And this is not only for healthcare, but what have we seen throughout this emergency that needs to change, as we can't go back to normal. We have to create a new normal. So why are we not providing people with longer prescriptions? Why are we not providing telephonic consultations for patients? And why are we not delivering medication to people's homes? When we first started having these discussions about providing telephonic support and doing home deliveries of antiretroviral therapy for people with HIV, the people who were the most resistant were healthcare workers, claiming that patients would be stigmatized. And actually, when we asked patients what they wanted, it was vastly different to how the healthcare workers had, vastly different to what healthcare workers had thought. We previously weren't given the opportunity to test out these new strategies, but COVID-19 has allowed us the space to do natural experiments and to reinvent our thinking around HIV care. It really allows us to think about patient care in a holistic way, and it puts aside our own agenda and misconceptions. So that's all.